Panel discussion on vitamin D, and we'd like to invite use and misuse of vitamin D, and we would like to invite our moderator, Dr. Jayashree, to please come and take over the proceedings.
So good afternoon, everyone. I am Dr. Vaishali Naik. I am the moderator for the session, and I have a co-moderator, Dr. Jasmeena Vora. We had some changes in the panelists, so Dr. Jayashree Shembalkar is going to be one of the panelists. And today there will be a discussion on vitamin D use and misuse. Why we selected this topic is, especially after the COVID era, we have been seeing that every other patient, not only a patient, but even the relative, they know what is vitamin D. They may not know their hypertension tablets, they may not know what diabetes tablets they take, but they are all on vitamin D supplements. So there has been misuse of this very good drug, and we all know it is an important, vitamin D is important in most of the aspects of human health. There has been hue and cry about the treatment of vitamin D in chronic conditions like type 2 diabetes, in cancers, in various infections. But many of the studies or trials have shown that only when the vitamin D is very severely deficient, then only it has been helpful in chronic conditions. What we are going to learn today or discuss today is about vitamin D use in our day-to-day patients. And as you know, it is an over-the-counter drug. In India, all the drugs are OCT. And not only the lay people who come to us as patients, their friends, their relatives, our friend physicians, and not to forget dietitians. I think all dietitians prescribe vitamin D, and they don't prescribe only the usual cholecalciferol, they prescribe calcitriol to all of our patients. So it is an over-the-counter drug, and it does really have many, many side effects if treated or misused. So today we are going to discuss with our panelists regarding the use and misuse of vitamin D. We are going to have 3 cases. They are simple cases, and they will tell us how to use this drug efficiently so as to have a satisfying result and not overzealously treat vitamin D deficiency. So I will welcome gives me very great pleasure in welcoming Dr. Pramod. He has been my senior, and he's a very eminent endocrinologist from Nagpur. He is the founder secretary of Maharashtra Endocrine Society. A warm welcome to Dr. Pramod. And Dr. Parag Shah, he is the director of Gujarat Endocrine Center from Ahmedabad. He has more than 50 publications, and he was the organizing secretary of ESICON. And yes, of course, Dr. Jayashree Shembalkar, a very good friend, my first teacher in endocrinology. Please welcome to you all. So we start with the first case. Jasmeena and me both are going to moderate. Yeah, I think they will have to.
Wants us to sit there and talk. So
no, I think you will have to face the.
we are okay.
That's okay? Okay. So we have a 40-year-old female who is mother of 4 children, and she's been a hypertensive and diabetic and following up with us. She's well controlled on a single drug for hypertension. What she complained was of aches and pains and had difficulty in climbing stairs on a second floor flat, and hence she came to the physician. So on examination, she was found to be a petite woman of 155 centimeters with only 52 kg weight, and clinically she was euthyroid. Clinical examination showed that she had proximal myopathy in both the lower limbs. So she was advised certain tests which showed a calcium which was 7.9, a phosphorus of 2.9, and an alkaline phosphatase of 212. So she was asked to do further tests, and we found that her PTH was 200 and a vitamin D level of 6. Rest of the parameters were normal. So I would like to ask Dr. Parag, what would be the diagnosis in this patient, and how do we stage vitamin D deficiency, and what is the treatment for this patient?
See, the first possibility, of course, would be the vitamin D deficiency leading to some sort of a osteomalacia with secondary hyperparathyroidism. But we have to rule out some other history also, like her renal status should be normal. She should not be having a renal insufficiency, which can be coexisting along with us vitamin D deficiency, or she don't have any malabsorption syndrome leading to the vitamin D deficiency and secondary hyperparathyroidism. So straightforward, most common would be the vitamin D deficiency induced some sort of osteomalacia because her alkaline phosphatase is high and vitamin D is severely low, and there is a definite evidence of secondary hyperparathyroidism. She got hypophosphatemia also. So most likely and most common would be the vitamin D deficiency leading to osteomalacia and muscle myopathy leading to the poor strength in the muscles as well as the bones. She might have some looser zones or pseudo fractures also if you do the radiological investigations. So if you talk about the vitamin D deficiency and its grading, we have a vitamin D level of more than 30 nanogram per ml is considered to be sufficient. 21 to 30 is the insufficiency, and less than 20 is the deficiency, and less than 7 or less than 10 is a severe vitamin D deficiency. So this lady would come into the severe vitamin D deficiency. Yeah. And if the renal function is normal and the parathyroids are normal and liver is normal, there is absolutely no role of a calcitriol, because calcitriol is abused by all the people because it is available in the calcium tablets also. So many times patients don't know that they are taking calcium, but actually they are taking the calcitriol. So we as endocrinologists, we don't use the calcitriol except if the patient has hypoparathyroidism or a chronic renal insufficiency, because then the 25 would not be converted into 125 hydroxyvitamin D or liver insufficiency. So the standard treatment would be very easy in such type of the patients. Give vitamin D, 60,000 is available as a sachets or a syrup. 60,000 once a week we will give for at least 6 to 8 weeks, followed by 60,000 units once in 2 weeks for couple of months, and then a replacement dose of 1,500 to 2,000 units per day. What would be expecting in such patients about the recovery? Her aches and pains and the muscle weakness should start improving after 2 to 3 weeks of time, though it will take 4 to 6 weeks for the remarkable improvement into the symptomatology. Then comes about the what lab investigation we should be doing. First, we will be, rather than doing the vitamin D, because we don't expect a vitamin D toxicity, because the more than 100 vitamin D levels is considered to be toxic, and with the just vitamin D given in the pharmacological dose, we don't expect toxicity. So we are not going to repeat the vitamin D levels just to monitor the progress or a sufficiency of the vitamin D is achieved or not. I think alkaline phosphatase we will be looking at after maybe 8 to 12 weeks of time, and PTH will take same 8 to 12 weeks of time. So patient should feel symptomatically better most of the time, because she is symptomatic for 6 months or so or a year. She should show a complete symptomatical improvement in maybe 3 to 6 months of time, and then she would be required a good calcium supplement and good vitamin D supplement for rest of the life, and good exercise and good healthy lifestyles for the good bone health to be followed for rest of the life.
Right. So do you recommend that in all patients who are started with vitamin D, should we do calcium levels as baseline? Because many a times we see that the patients do not have any basal calcium levels, and then they have been treated with vitamin D, and we do see toxicosis also.
I think at the first
So should we do that for every patient who is? Yeah,
anybody who has a skeletal metabolic problems, we will be doing the serum calcium values.
Yeah, so it
first.
Should be a must.
But subsequently, unless the patient has some other disease like a chronic kidney disease or patient on a calcitriol therapy or a teriparatide therapy, we will not be repeating the calcium frequently. If the calcium is normal or low normal in like such type of the patients, we don't keep on repeating the calcium values.
So what then with, if suppose we overtreat and there is normocalcemic hypoparathyroidism, so do you think
Just
that we should really treat them and then follow up with the calcium also?
We don't anticipate vitamin D toxicity if you are giving the...
It's not in this case, I'm just asking in general.
Yeah, you have to see which dose of the vitamin D and which form of the vitamin D patient is taking and what is the other underlying causes.
Right.
Like many of the times patient has a sarcoidosis or a tuberculosis, then the chances of having hypercalcemia is high. Many of the times orthopedics give the 6 lakhs unit of injectable therapy, 2 or 3 injections after the even non-traumatic fractures, traumatic fractures also. On top of that, they are given teriparatide, and on top of that, they are already on calcitriol. Then naturally we expect and we see lots of hypercalcemia, specifically in the elderly population when there is a dehydration or some nausea, vomiting occurs, then naturally we get lots of hypercalcemia. But just a simple vitamin D, if given in a proper dosage, does not lead to the hypercalcemia.
So Dr. Jayashree, want to say something?
Yeah, I just wanted to say that vitamin D deficiency itself has a huge spectrum.
Yes.
And what you showed now is a severe kind of vitamin D deficiency long term, which has led to such a severe bone disease. But when we are seeing patients in day-to-day OPD, we must target high-risk patients in whom screening for vitamin D deficiency should be done. Like patients who have multiple pregnancies, prolonged lactation, patients who are covered all the time, like burqa-clad women, or there are some elderly patients, or because of some illness, if they are homebound, then even those people are very much prone for vitamin D deficiencies. And these patients should also be screened actively for vitamin D levels and treated before they develop bone disease. Before they develop bone disease, if we are able to prevent
them
bone,
getting into
then
deficiency,
that is really something beneficial.
Yes. And what about pregnancy? Are there different treatment doses for
Of course, pregnancy lactation increases requirement. So we have to increase the dose of vitamin D, calcium. And we also have to emphasize them that as long as they are lactating, they need to continue taking supplements. Otherwise, usually what happens, once the delivery is there, they stop calcium and vitamin D. So even there is a huge bone loss in lactational period.
During that period.
Yeah. Pramod, would
Yes.
you like
Dr.
to add
Pramod, do
something?
you want to say anything?
Only one thing, like you asked
Can you have the mic?
I think only one point which you asked about the serum calcium level, doing serum calcium level. If in this case, probably if we would not have done serum calcium levels, you see patient's PTH was elevated, patient's phosphorus was low, patient had, if you would have done the investigations to evaluate for osteoporosis, probably patient might had some osteoporosis. So it would have been difficult to differentiate between primary HPT versus simple vitamin D deficiency.
Exactly.
So doing one serum calcium level is very important. And the second thing is about vitamin D toxicity is usually maybe up to 4,000 units of vitamin D per day is a safe limit, upper limit of safe vitamin D levels which can be given safely daily, which is unlikely to cause hypervitaminosis.
I want to ask a question here. Do you need to give so much of vitamin D? I'm confused by this thing. How much vitamin D do you need to maintain a vitamin D level of 20? Do we need 30? 30 and above is mentioned as preventing other disorders where there is no evidence.
30 to 50,
so most of the
which is
people
recommended.
say 20 is a recommended. National Osteoporosis Foundation says 20 is sufficient to maintain the bone.
So they say that
Correct.
if it is less than 20, then the PTH starts going up.
Yeah.
So we need to have it at least 20 and up to 30. So
and if you see IOM, then they will say that even with 12 of
12.
vitamin D,
Below 12 is severe vitamin D deficiency.
so there is a variation in the thing.
Yes.
Number two, why do we need to do vitamin D levels at all where we suspect burqa clad all the time? Why can't we directly treat a small dose? If you give 6,000 units or once a month treatment, what is going to happen to them? They are anyway not getting any vitamin D. No, I'm just asking questions because the cost of doing vitamin D is more than 1,500 rupees.
No,
So in
I would
a
really
treatment is done.
want to say here that yes, sir.
I tend to agree with Madam because in our country, I think so, 90% of our women are vitamin D deficient. They may not be severely deficient, but they're definitely less than 20. They're not, maybe not be 6 or 7 as I said. So what she rightly said is perhaps in the setting of when we see these elderly women or such communities, I, for instance, very often give vitamin D without actually doing vitamin D levels in the lower socioeconomic groups. Because the moment you tell them to do a test, they run away from the clinic.
So I think we may miss a hyperparathyroidism in that case. If we just treat, if we don't do a basic calcium, we do see cases who have been treated without doing calcium. I have seen several such cases. So I myself feel that at least a basic calcium has to be done. Whether you do vitamin D or no is okay depending upon the availability.
Even I feel that even basic vitamin D
yes.
level should be done. Because once you see a vitamin D toxicity case,
Yes.
it becomes very essential that patients who can afford one vitamin D level should be done.
Ma'am, what you
And your
say, we
prescriptions-
agree.
What you say, I agree with you. A symptomatic patient like this case which you're discussing, you definitely have to do both calcium as well as vitamin D in a symptomatic
Yes.
patient. But here we are talking in a general setting. In your clinic, when patients have come with no symptoms relating to vitamin D.
So we are saying
So
in
you are-
high
we are
risk
talking
patients.
More of a preventive type of a approach rather than a diagnostic type of approach.
Yeah. That is what I am saying. Preventive type of approach. Yeah.
Okay, thank you so much. And now, Dr. Jasmina, will you take over for the next case?
We have our next case. As this is a 55 years old lady who's been diabetic and hypertensive for several years. She's been recently diagnosed to have chronic kidney disease. She presented with worsening lower back pain and proximal myopathy at the hips. And on examination, she had local tenderness at L3, L4 region. Reviewing her past records revealed that her creatinine was 1.5 milligrams % around 2 years ago, which was corresponding to an EGFR of 42 ml per minute. And that has now reduced to 14 ml per minute, corresponding to a creatinine of 4.5. Other relevant current laboratory reports reveal that her calcium was 6.7 milligrams % with an albumin of 3.4 grams and phosphorus of 6.5 with an alkaline phosphatase of 320 milli-international units per ml. Her bicarb, venous bicarb was 19, suggestive of metabolic acidosis, vitamin D of 10 nanograms per ml, and PTH was raised with 250 picograms per ml. X-ray of her lumbosacral spine showed there was a compression fracture at L3, L4, and there was rarefaction of the visible spine. So with this information, I'd like to ask my first question to Dr. Pramod. What would be your next relevant therapeutic step, and what do you think is the issue here?
Now, reviewing the history, she is a postmenopausal lady who has chronic kidney disease, and along with that severe vitamin D deficiency, hypocalcemia, high PTH, hyperphosphatemia. So this is a classical case of vitamin D deficiency in a patient with chronic kidney disease. Along with that, she has L3, L4 fracture. Probably it's a osteoporotic fracture. And now, since patient has osteoporotic fracture, a fracture at L3, L4, we obviously know that DEXA is not going to help to evaluate the osteoporosis, but then that's a clear-cut evidence that it's a severe osteoporosis. So it's a patient who has chronic kidney disease with severe osteoporosis leading to vertebral fracture. And it's usually, if you see in patients with chronic kidney disease, the osteoporosis is due to secondary hyperparathyroidism, which this patient had. This is due to the conversion of 25 hydroxy vitamin D to 125 hydroxy vitamin D doesn't happen at the renal level. Therefore, there is vitamin D deficiency in this patient, which leads to secondary hyperparathyroidism. Also, the vitamin D deficiency leads to decreased absorption of the calcium from the gut, and that also again leads to secondary HPT. So, if patients' PTH levels are high, this leads to bone resorption, and this leads to osteoporosis. So, what is the next therapeutic intervention? Obviously, this patient needs, particularly in this patient, she needs vitamin D, along with other treatment of osteoporosis which we have discussed in the previous talks also, the vitamin D which needs to be given is 125 dihydroxycholecalciferol. Here there is a definite role of calcitriol. It is recommended that patients up to grade 3 CKD, we can use conventional vitamin D, D2, D3 preparations, but grade 4 and grade 5, these are the only patients where we should restrict our use of calcitriol in this group of patients. But in the recent KDIGO guidelines, there was one more thing which was mentioned and which I would like to tell you about is, in addition to calcitriol, they recommended that we should also use conventional vitamin D. And this is not to the benefits on metabolic bone disease, but then extra skeletal benefits of vitamin D. You will get it by conventional vitamin D preparation. So they recommended to use both vitamin D as well as conventional vitamin D along with calcitriol in patients with chronic kidney disease. So the role of calcitriol is particularly limited only in this group of patients. Up to stage 3 or grade 3 chronic kidney disease, calcitriol use is not recommended. It will cause more harm, it will cause hypercalcemia, it will probably increase the cardiovascular morbidity as well as mortality if we use it calcitriol excess in these patients.
How about alpha calcidiol? Would you use it because it is only the 1-alpha hydroxylation which is impaired at the level of kidneys?
Again, alpha calcitriol is not recommended in patients with chronic kidney disease. It's only calcitriol which is recommended in patients with grade 4 and grade 5. Up to grade 3 you can use any of these preparations of vitamin D.
So the next thing would be, was this fracture preventable? I mean, how do we approach CKD patients in general? And also, because there was high PTH, sometimes we see that patients come with a sestamibi parathyroid scan. So whether such a test is required?
No, definitely in all patients with chronic kidney disease, it is recommended that those patients who are at high risk of development of osteoporosis, in addition to chronic kidney disease, these patients BMD should be assessed in all these patients whose CKD is between grade 3 to grade 5 staging. Up to grade 2 it is not recommended, but then above grade 3 all these patients BMD should be evaluated, and if you find that patient has osteoporosis, this patient should be subjected for anti-disruptive therapy to prevent the occurrence of fracture. So they definitely, if this patient would have been treated early, the fracture could have been prevented in this, probably it could have been prevented in this patient. Since this patient has, patient's calcium was 6.7, which was hypocalcemia, hyperphosphatemia, along with high PTH, it's a classical chronic kidney disease or secondary HPT basically, not primary HPT. In primary HPT, you will get high calcium, low phosphorus and high PTH. So this was a classical secondary HPT. So there is no role of parathyroid scan, absolutely no role of parathyroid scan in this patient.
Correct. So just like here, as you said, that calcitriol would be the best thing to use. Are there any similar, I mean, would you use something different in, say, chronic liver disease patients or say in patients who have malabsorption? I mean, would you want to use some different form of vitamin D than the usual cholecalciferol?
In patients with chronic liver disease also we can use calcitriol safely, because again the conversion of cholecalciferol to 25 hydroxycholecalciferol doesn't happen in the liver. So in these patients also calcitriol can be used safely, or those patients who has malabsorption, in these patients calcitriol can be used safely.
Thank you, Pramod. Let's move to the third case.
Yeah, any other comments from Dr. Parag or Dr. Jayashree?
The only thing when we are giving calcitriol in such type of the patient, we should be monitoring the calcium values, just to make sure that because we will be giving calcium also along with the calcitriol. So maybe initially after 3 months and then maybe after 6 months, we should be monitoring calcium values also.
Again, in these patients,
Because the
I
patient
just
might go for, because of the nausea, vomiting, she is grade 4 or probably grade 5. So she might get dehydrated and she might get hypercalcemia. So in such type of the situation, we might be monitoring the serum calcium. Yeah.
to prevent hypercalcemia. Again, one more thing which we just spoke about the vitamin D preparation and the serum calcium. Phosphate levels are high, phosphorus levels are higher, so phosphate binding agent should be used to reduce the phosphorus level. That is also going to help you to reduce the risk of osteoporosis in these patients.
So we'll go to the next case. So we have a 80-year-old female who was admitted with delirium. She had no comorbidities. Healthy woman. She had a fall 2 years back, fractured her femur, operated, and then she was put on calcium and vitamin D supplements. General condition was otherwise, general examination was normal, hemodynamically stable, no acidosis, no focal neurological deficit, but she was found to be delirious. So all her biochemistry was normal except her serum calcium, which was 12.7. So Jasmeena, you want to did it? So Dr. Jayashree, what is the likely cause of
Serum calcium, phosphorus level.
So what is the likely cause of? So do you want to know the serum phosphorus levels? 4.5.
I would also like to know her urea creat.
So vitamin D, 25 hydroxy vitamin D.
Creatinine.
Creatinine was 1.2.
1.2.
She's
PTH?
80-year-old with a range of,
PTH?
sorry?
PTH.
So PTH was like 10.
Vitamin D?
So it came to 200.
200.
Yes.
Okay.
So
Yeah, sir.
the
guessed
most
it
likely
rightly.
cause of,
Yeah.
obviously.
Yeah. So this was a case, I would attribute this hypercalcemia definitely to vitamin D toxicity.
Yes.
And I would like to go in detail about the history after fracture, what vitamin D doses, calcium doses were given, was she monitored, was she following up with the orthopedician, or
So
was she blindly
was not
taking?
monitored, and her calcium vitamin D was continued for 2 years, and she was taking weekly vitamin D sachet, and then she landed up with this. So was this preventable?
Of course it was preventable. We all
So,
see such
so in the first case we said that we shouldn't do calcium. So should we have done a calcium for her? I mean the orthopedic or whoever treated at the onset before he started. We do not have any reports.
I think her hypercalcemia is because of vitamin D toxicity.
Yes.
Overdoses.
Yes.
So monitoring of whatever calcium vitamin D has been given,
Yes.
either the physician, the prescribing physician has to monitor, and the patient also has to follow up with the physicians.
Right.
Many times we have seen that without consulting anyone, they continue taking vitamin D sachets or whatever preparations just because it makes my bones strong.
Yes.
Yeah.
So, what are the manifestations of vitamin D toxicity?
Like
usually?
you said in this patient, CNS manifestations like delirium, confusion, convulsions. Even I have seen patients who are in almost comatose state.
Yes.
Sometimes they can, in early, like they can have loss of appetite, nausea, vomiting, and of course renal complications like nephrocalcinosis with long-term unmonitored vitamin D supplements, they can have all these problems.
So, what level of vitamin D do you take as toxic level? What do you recommend as the ideal level? She's an 80-year-old woman.
She's an elderly woman. Toxicity level, whatever books mention, is more than 150. But they say not to go more than 50. And even more than 30, there are no added benefits. So it's best to keep them between, say, as madam said, between 20 to 30, but not to go beyond that.
Okay.
In fact, some of the literature says if you go beyond 50, the fracture protection or fracture prevention is not there, and there are some risks of malignancies. You also read that?
Recently I read the literature about the chronic vitamin D toxicity, which is seen even in those patients whose vitamin D level is maintained above 50 for a prolonged period. It was found that there is increased risk of fall, increased risk of fracture, increased risk of malignancy, increased risk of cardiovascular morbidity as well as mortality. So, though the classical vitamin D toxicity which is suggested is above
Acute,
150 acute, but then chronic vitamin D toxicity is above 50. So, don't let your vitamin D go above 50. Try to maintain it below 50. The recommended is between 30 to 50.
So in some patients, they are asked to do 125 vitamin D levels. Do you really recommend that? She
125.
came with hypercalcemia, so I am not saying us, but there are people who do even 125 vitamin D, or many a times we come across reports that instead of vitamin D, they have done 125 vitamin D. So should they be done or not done at all?
125 would not reflect the status of the vitamin D.
Right.
We will recommend only the patients with a very rare conditions of vitamin D resistant rickets or vitamin D dependent rickets, where there is
in case of hypercalcemia.
not otherwise.
So probably 125 might help in patients with chronic kidney disease also, but then it is not recommended.
So we don't recommend.
It's not recommended.
So
Comment. There was a patient admitted in the hospital, Jupiter Hospital, with hypercalcemia 15. 15 was her level on the day of 15 milligram per DL. They tried, they didn't do phosphorus as usual. They tried everything, and they did even scan for pancreas, then they did for malignancy. All that thing they did, and finally they decided we can't decide, so let's call Menon. So when I went to see, and I also couldn't understand because everything under the sun has been done. So I just sat with her and started taking her history. What she was taking was that for 3 to 4 years or even 5 years, she was taking Gemcal, 1 TDS. Somebody prescribed Gemcal for her after admission somewhere because she is old, to prevent postmenopausal osteoporosis. She's been taking Gemcal 3 times daily for 3 to 5 years. And that was the cause. Stopped Gemcal, and within 15 days the cat started coming down, and she went home and she became 11 milligram per deciliter. So people do prescribe. Gemcal is a very common prescription in our country. And if patient decides to take for a very long time, beware of hypercalcemia.
Yes. Except endocrinologists, I think most of the calcium supplements prescribed by the orthopedicians and physicians is with the calcitriol. So
sometimes
I don't know.
We don't even know the names.
We should ask the authorities to stop this combination of calcium with a calcitriol. We as endocrine society should recommend, because lots of patients are on a calcitriol twice a day along with the calcium. And they just consider we are taking just a calcium. And nobody takes the history of the calcium orthopedicians. They keep on giving the injectable calcium, and on top of that they give the calcitriol, and they start with the teriparatide even in a non-traumatic traumatic fractures for a fracture healing. So all together leads to hypercalcemia and vitamin D toxicity.
I was very tempted to take one prescription to the court by an orthopedician who prescribed to a patient of mine injection Racetol daily for 7 days and then every 2 weeks for 3 months. And he signed it. And he signed it. Now, isn't this
7 days is a very common
legal document?
5 to 7 days injectable 6 lakhs is very common from orthopedicians.
So even atorvastatin tablets, they are combined with vitamin D, right? So patients don't even know that they are taking vitamin D in so many forms. Okay, so Dr. Jayashree, what is the treatment? This patient is in delirium, her calcium is 12.7, it was repeated. They thought it's a wrong report, they repeated it, and it is 13. And she is still delirious.
Yeah, this patient definitely needs to be treated urgently, because she already has CNS bad effects of hypercalcemia. So she should be given intravenous fluids, intravenous Lasix to rapidly bring down her calcium level. And of course steroids help because they will inhibit absorption of calcium. Vitamin D, and the most important thing to tell them is to stop vitamin D supplementation. Otherwise, even after going home, same thing may continue. Bisphosphonates are also used for treatment of hypercalcemia, and they do help in urgent control of hypercalcemia.
So sometimes we do see that steroids are not helping. So to tide over the crisis, we use zolidronate. Fortunately, her creatinine is 1.2, but if it was 3, then just hydration and okay. So how long do you give the steroids?
Steroids maybe, I think 10 to 15 days, I have no idea, but 10 to 15 days, and I'll monitor calcium again and then decide whether steroids need to be given further or not.
Okay, and how do you then, how long does it take to normalize this calcium level?
It really depends on what type of calcium the patient was taking, and whether it was a 25 hydroxy vitamin D, which will take much more time to be cleared from say liver, muscles and fat tissue. So it may take months or maybe sometime year to clear off.
Okay, so
but if calcitriol has been taken, then they respond very well in days time, but otherwise they may take weeks or months.
So do you recommend to do the repeat vitamin D level, and after how many weeks?
Usually calcium level should suffice.
Yes. So thank you so much. Yes.
Suppose this patient presented with a high creatinine as well, say 2, 3 or something, would our therapeutic approach be different, or would it mean something different in terms of the outcome of renal insufficiency because the calcium is high?
Sometimes significant renal insufficiency patients just not respond to the hydration and diuretic therapy or a steroid therapy. I know a couple of patients had to undergo dialysis actually for the severe hypercalcemia of more than 15 not coming down, and patient had lots of CNS symptoms. I remember a couple of patients has to undergo hemodialysis.
In such patients, the renal failure is possibly because of persistent hypercalcemia,
in acute
nephrocalcinosis.
It could be reversible on correction of hypercalcemia.
So it's a usually irreversible condition. So this patient might need, as Dr. Paragas said, renal replacement therapy.
Okay,
there are some other drugs which has also been tried in the, which is mentioned in the literature, is about barbiturates, phenobarb, or maybe chloroquine and quinolones has been tried to reduce the even ketoconazole. These are the drugs which has been tried to reduce the hypercalcemia
due to vitamin D toxicity.
Yeah, vitamin D toxicity.
Okay, so are there any special situations in which do we have time? No? Okay, thank you. And Dr. Jasmeena, will you just summarize the session for us?
Sure. So I'd just like to say that this entire session was a true amalgamation of hormones and bones, justifying the title osteoendocrinology. Wide use of steroids often overlooks that osteoporosis eventually comes, and this merits that every prescription of steroid is packaged with vitamin D and calcium. This fact was very beautifully explained by Dr. Chadda. Also, declining bone density as a natural outcome in a woman, young woman who's undergone early menopause, it just adds to her misery. How to deal with and which agents to use was simplified by Dr. Usha Sriram. Vitamin D is more hormone than vitamin, as we all know, and it should be judiciously and thoughtfully prescribed depending on the need of the patient and background of the patient. And our expert panelists have highlighted these issues beautifully. Thank you all. We thank the audience for making the session interactive. And on behalf of Jayashree, Vaishali, myself, and the team of We Care, thank you all. Thank you, Chairperson.
Thank you.
Thank you.